Hi, everyone, and welcome to part one of our NCLEX Medsurg review. The Medsurg portion of the exam makes up the bulk of it, so therefore we're going to be breaking up this Medsurg content into three pieces. I'm super excited to start this with you guys. As always, I am not affiliated with ATI or the NCLEX boards themselves. I am a registered nurse. I took my boards back in May of 2023. And essentially, as I personally was studying for my boards, these are the notes I compiled from various resources, textbooks, and rationales from practice questions. So as always, this is strictly a content review. We're not going to be doing practice questions, going over test taking strategies, anything like that. Essentially, what this is for you guys is a content review for you to have a little bit of self-reflection to see, okay, what do I remember? What do I need to freshen up on? And what do I need to focus my studying efforts? Ideally, during your kind of 6-week prep before your boards, you should be aiming to do about 75 to I'd say 150 practice questions a day. It's very important not only to do the practice questions to get a better feel for the exam, but also really, really focus on understanding those rationales. So, additionally, if you guys would like a copy of this PowerPoint in PDF form with notes, I have them available for purchase on my Etsy. The link is going to be in the description. So, what are we going to be talking about today? For part one, we're going to be going over our need to know labs, fluid and electrolytes, our acid-base imbalances, pre-op, post-op, intra-op nursing, and end-of-life care. So, what are our need to know labs? We've got our electrolytes, our EBGs, CBC, lipids, coags, and liver function tests. We'll spend a bit more time on ABGs in the upcoming slides as we talk about our acid-base imbalances. But it's important to understand what are our normal values for electrolytes and what can happen if we stray away from our normal. So I think the two most important electrolytes to understand are going to be sodium and potassium. Our normal levels of sodium range between 135 to 145. I always say salty seizures. If we have any sort of imbalance in sodium, especially hyponatremia, it puts our patient at increased risk for seizures. It can also cause dehydration issues where they can be intravascularly dehydrated. If we've got too much sodium, it's pulling water where it shouldn't go, et cetera, et cetera. Also, potassium. Potassium pumps the heart. Any sort of potassium imbalance we have, we're going to see some cardiac issues. So if your patient has potassium outside of the normal limits, we're going to want to make sure that we've got them on continuous telemetry monitoring. Okay. We've also got our mag, our phosphate, and our chloride. Okay. Mag is important because too much mag can cause additional issues, which we'll talk more about in women's health, and we'll talk more about in our body systems review. Okay. ABGs, we've got pH, we've got carbon dioxide, we've got bicarbonate, and PaO2. Again, we're going to focus more on that in the next slide. Up next, we have our complete blood count. This tells us what our patient's red blood cells are, what their hemoglobin hematocrit might be, and really what we should expect within the patient's blood. So ideally, RBCs should be between 4.2 to 6.1. Hemoglobin 12 to 18. Again, these are ranges. They differ based on gender. It's more important to just to understand the grand scheme of things. Okay, usually we want that hemoglobin between 12 and 18. Anything less than 12, we start getting concerned. Okay, we start thinking maybe if they have a hemoglobin of 7, we might need to correct the underlying problem. Maybe they're bleeding out, and maybe we're going to need to get a blood transfusion going for them. Same thing with our hematocrit. Our white blood cell count, again, People ask all the time, should I memorize verbatim what these are? Yes and no. I'd say more so understand what our abnormals are. So if a patient's white blood cell count is elevated, meaning it's over 10, your patient has a white blood cell count of 14, that's elevated. That is greater than normal. We're thinking there might be some sort of infection or autoimmune response going on. And then finally, we have our ESR. Up next, we have lipids, which is a huge education point for patient education, especially for cardiac patients. We want to encourage their total cholesterol levels to be less than 200. We want their triglycerides to be less than 150. We want their LDL to be less than 130. And we want their HDL, which is our happy cholesterol, our good cholesterol, we want it to be high. We want it to be greater than 45 to 55. Coagulation panels are super, super important in pharmacology and for cardiac. Okay, we've got our PT, prothrombin time. Our normal is 11 to 12. More so understand the therapeutics. We're going to focus more on this in our cardiac pharmacology lecture. But really, what does therapeutic mean? It means that if a patient is on a medication to essentially thin their blood thinners, anticoagulants, things of the sorts, they're most often given to cardiac patients that might be experiencing a myocardial infarction or patients that recently had a stent placed. What we're trying to do is promote more blood flow through the heart. And to do so, if our heart is very, very narrow, we need our blood to be super thin and super slippery so that it can kind of get to where it needs to go. So we want to give them medications that help that. That's going to be our warfarin, that's going to be our heparin, and we want to make sure that our levels are therapeutic, okay? PTT, we want between 45 and 65. Sorry, APTT, we want 45 to 65. Our PTT, we want around 90. INR is super important for warfarin. If your patient is on warfarin, we want their INR to be between 2 and 3. Up next, we have our platelets. Platelets make the blood super, super slippery. So our normal platelet count is 150 to 400. If their platelets dip below 20, we start getting concerned. Okay. Alrighty, and last but not least, we have our liver function test. This is more important when we're thinking anything hepatology related. We also look at our LFTs sometimes when we're thinking about prescribing medications. How is their liver doing, given the fact that the liver helps detox our body from lots of medications? We've got albumin, 3.5 to 5. This also helps our patient helps us get a better idea of how well nourished is our patient. Are they getting all the vitamins, minerals, etc. that they need? Up next, we've got ammonia between 10 and 80. If our ammonia levels are really, really high, we might see some encephalopathy going on, some altered mental status. Up next, we have our bilirubin. Usually if we talked a lot about this in our pediatric review, but if a baby's bilirubin levels are high, they're greater than 1, they're elevated, we start to see some jaundice in the baby. Finally, protein should be between 6 and 8. What should we see in our patient's urinalysis? We see specific gravity, protein, glucose, pH, white blood cell count, PSA, urinary output. I personally think urinary output is the most important thing. We want to make sure that our patient's urinary output is greater than 30 mLs an hour, okay? If you had, let's say, a patient that suffered massive trauma and you've had them for 12 hours and they've only produced 200 mLs for the entire day, that's 200 over 12 hours. That's definitely not making our 30 ml an hour rate. So we're going to want to bladder scan them. Maybe they're dehydrated. Maybe there's some other issues going on. Our PSA is can be elevated for patients with benign prostatic hypertrophy or prostate cancer. So that's kind of something to be aware of as well. Renal panels, super important, BUN and creatinine. Most often, patients, whether they'll be going for a procedure involving contrast dye, or maybe we're going to start them on medications, you always have to make sure you know what their BUN and creatinine are. we're more concerned if BUN and creatinine are elevated. If the creatinine is greater than 1.2, if the BUN is greater than 12, this means that the kidney's function is compromised, especially in patients maybe with chronic kidney disease or acute kidney injury. These will be elevated, so it's super important that we see what's going on. If we're trying to figure out maybe this is chronic kidney disease, we can look at their creatinine clearance. This takes 24-hour sample of urine and really lets us get a bigger, broader picture as opposed to like a one-time urine culture. Okay. And then finally, sugar. This is very important when we talk about our endocrine system. But ideally, the fasting blood glucose should be between 70 and 105. Again, that's not going to immediately diagnose somebody with diabetes. What we do is we look at the HbA1c, should be between 4 and 6. Again, bigger picture, more data. Essentially, anything greater than 8 is probably indicative of some diabetes going on. Okay. Finally, we've got therapeutic drug levels. We're going to talk about this in pharmacology, don't worry. But essentially here I have 5 drugs listed. They have very narrow therapeutic index. So what does that mean? There's a very fine line between therapeutic and toxic. Okay, so these drugs can get very toxic very quickly, especially our psychiatric medications such as our phenobarbital, theophylline, and phenytoin, like seizure-related medications, mood stabilizers, but also digoxin and lithium. Lithium treats bipolar, and digoxin is used heart failure, helps, improve cardiac output, cardiac function. Again, it's a very important drug, but it can get very toxic very quick. So you want to keep an eye on these levels. Again, we'll focus more on that in pharmacology, but again, it's just good to know. Alrighty, moving on into acid-base imbalances. I strongly encourage you guys to just do a couple acid-base imbalance practice questions on your own. There's tons of great websites, tons of great resources. Again, it's practice by repetition. So, what is our body's normal pH? We've already discussed that. It's going to be between 7.35 to 7.45. That is our nice, beautiful, sweet spot. Anything less than 7.35 is going to be acidic. Anything greater than 7.45 is going to be basic. So we've talked about pH. Let's talk about carbon dioxide. So carbon dioxide is an acid. Our nice neutral sweet spot for CO2 levels is going to be between 35 and 45. This helps keep, everything neutral. If we have increased levels of carbon dioxide, let's say our CO2 is 50, that means we have more acid. Therefore, we could see our pH be shifted to an acidotic state. We're going to talk about that when we talk about the imbalances, but just understand what are our normals for carbon dioxide and how would anything outside of normal impact our pH. If we have more CO2, we have more acid. On the flip side, we have bicarbonate. Bicarb is used in our body's metabolism. Bicarb is basic. Our normal bicarb values are 21 to 28. If our bicarb is elevated, if our bicarb is greater than, if our bicarb is 35, it means that it's going to cause our pH to shift to be more basic. Bicarb is basic. Therefore, pH is going to go up. Up next, we have SaO2. This is our patient's oxygen saturation. This is if we do a pulse ox on the finger. What's it going to be? Normal value should be between 93 and 99. Caveat, remember our patients with COPD, they tend to have a SaO2 usually between 88 and 92. That's their normal. Again, we'll talk about it when we talk about body systems. So, last but not least, we have PaO2. This is arterial pressure of oxygen. Only way to get this value is going to be from an ABG, arterial blood gas. How do we get an arterial blood gas? We're going to draw blood from the artery. Usually it's respiratory therapy or a provider that is certified to do this. But it must come from an artery. It's going to come from our radial artery. How do we know that it is in fact in an artery? We perform an Allen's test, which we'll talk about in the respiratory review. Normal values are going to be between 80 and 100 for that mean arterial pressure, that PaO2. So let's talk about some imbalances. First thing we're going to talk about is if the issue is a metabolic issue. So what did we talk about earlier? That was a product of metabolism that was involved in the body's metabolic kidney buffer system. Bicarb. So if we have any issues with bicarb, whether it's too high, too low, this is going to be a metabolic issue. Things about metabolic issue is our abnormals are going to move in the same direction. So first step, always, what's your pH? That's the first thing we look at. We'll figure out if it's metabolic or respiratory later, but the easiest thing to find out is the pH. So always look at the pH first. If our pH is low, less than 7.35, this is acidotic. So what might be causing acidosis? Well, let's look at what else is going on in our ABG. We see that the bicarb is low. So if we are missing, so we're essentially missing a base. We don't have enough base. So if we're missing a base, we're missing something that's basic. This is going to cause our body to kind of shift into an acidotic state because we're missing that nice even, it's like a seesaw. Too much in one direction, too little in the other can cause an imbalance. So we've got a low pH and a low bicarb. That's metabolic acidosis. So what might cause metabolic acidosis? Diabetic ketoacidosis, ingestion of salicylates, patient having seizures, or diarrhea. So what might we see with this patient? We might see some decreased reflexes, hypotension and bradycardia. We'll see some increased respirations, a little bit of confusion, and we'll see Kussmaul's breathing. That's more common in our diabetic ketoacidosis. Essentially, that's the body's way of compensating, trying to blow off some carbon dioxide, trying to blow off some acid. So moving on to metabolic acidosis, we look at the pH. The pH is greater than 7.45. That means the patient is in some form of alkalosis. So let's look at the bicarb. Well, bicarb is high. Our bicarb is greater than 28. So we have too much base. Too much base can definitely put us in an alkalotic state. They're moving in the same direction. The pH is high and the bicarb is high. That's going to mean we're metabolic alkalosis. What might cause metabolic alkalosis? Ingestion of acids. If the patient is on GI suction, some hypokalemia, the patient's on TPN, or the patient's experiencing a lot of vomiting. What might the patient experience? They might have some paresthesias, some decreased respirations, and dizziness. So now let's flip to the respiratory side of things. So what component in an ABG is responsible for respiratory? Carbon dioxide. We inhale oxygen, we exhale CO2. So again, always look at the pH first. If our pH is less than 7.35, they're going to be acidotic. The pH is low. So let's look at our other components. If we see an abnormality in the carbon dioxide, we've got a high CO2. Our CO2 is greater than 45. We have too much acid. That can definitely make our pH acidotic, so it matches. We're therefore going to have a respiratory acidosis. Respiratory issues go in the opposite direction. So the pH is going to be low, but the carbon dioxide is going to be high. What might cause respiratory acidosis? Patient having respiratory failure. Patient maybe has a pneumothorax or not having proper gas exchange. They might experience some dizziness, some palpitations, and some convulsions. What's going to be the treatment for this? We're going to want to establish an airway. Okay. Alrighty, now we have respiratory alkalosis, meaning our pH is high. So what might cause a pH to be greater than 7.45? Let's look at our carbon dioxide. Our carbon dioxide is low. We have too little CO2. We have too little acid. That's going to cause us to shift to an alkalotic state. The pH is going to be high, but the bicarb is going to be low. What might cause respiratory alkalosis? We got some hyperventilation, asthma, high altitudes, and hypoxemia. Patient will experience some anxiety and might have some increased respirations. The treatment for this is going to be a non-rebreather mask. Alrighty, moving on into our perioperative care. We've got pre-op, intra-op, and post-op. The most important thing for pre-op care is going to be our informed consent. So not only are we witnessing informed consent, we're also determining whether or not the patient is able to make informed consent. So number one, the patient has to have been explained the procedure, the risk versus benefits, by a physician. It is not the nurse's responsibility to provide this information. It must be received from a physician. We're going to witness that it occurred, meaning the patient has to be able to understand. It has to be in easy, understandable, digestible terms to the patient. The patient can't have any serious questions like, oh, are they going to cut me open? Now, absolutely, the patient might ask, will I feel sick after the procedure? Well, yeah, we can kind of answer those questions, but anything major, if they're not understanding, it means that they really didn't get informed consent. We also have to make sure they're able in the first place to get informed consent. If your patient has history of Alzheimer's, dementia, maybe they have new onset confusion, maybe they are comatose, or maybe they have received heavy sedating medications where they're not alert and oriented enough to receive that education. It's up to the nurse to perform a timeout. And we might need to then get informed consent from a family member. Okay. Now is also the time where we'd be reviewing medical history, reviewing pertinent labs, getting some vitals, making sure before procedure, patient is NPO, nothing by mouth. If this is a scheduled procedure, we're going to hold anticoagulant 7 to 10 days before the procedure. And now would be the perfect opportunity to educate on post-op care. What would post-op care mean if the patient had a lap chole? You know that they're going to have a pretty large incision on the abdomen. Now would be the time to educate. Avoid showering for 24 hours, make sure we're doing coughing and deep breathing, we're wearing our abdominal binder, we're splinting the incision, because after the procedure, when the patient's in pain, they're out of it, they're not as receptive to this education. So actually during the pre-op phase of care, we're going to educate on post-op care. Intraoperative, this is in the OR. It's very important that nurses are helping with marking the site. If it's an amputation, we're marking what site that the patient is getting amputated, and performing a timeout before proceeding with the procedure is very important. They are also to use surgical asepsis. So, post-op, what are our priorities for post-op care? Number one, it's going to be airway. When in doubt, we always follow ABCs, airway, breathing, circulation. Airway is going to be our priority. After surgery, we're making sure the patient has a pain airway, their gag reflex is intact, and we're going to want to keep them in semi-Fowlers. Okay. Also, getting a set of vitals, making sure they're stable. We're assessing level of consciousness and movement. We also really want to make sure that they're having good urinary output as well. And we're frequently assessing these surgical sites for any signs and symptoms of infection, maybe some dehiscence, evisceration, etc. So, what are some post-op complications? First one's going to be atelectasis, when our little alveoli might have closed up a little bit. This is why ambulating a patient after surgery and having them use that incentive spirometer is so important. We want to make sure that those little alveoli, the sites of gas exchange, are nice and open so that the patient can take in that oxygen, use it, send it in the bloodstream, all that good stuff. So what might we see with a patient with atelectasis? Tachycardia and tachypnea with decreased oxygen saturations. Again, this is because the little alveoli are filled with some fluid and can no longer perform gas exchange. Treatment for this is going to be incentive spirometer use. If that's not effective, patients will actually need to be put on mechanical ventilation. Up next, we got pneumonia. This is when fluid deposit in the lungs, most often a complication of staying in bed, not using a central spirometer, etc. Patient will have tachycardia and tachypnea. Upon auscultation, you'll hear some crackles in the lobes of the lungs, usually those lower lobes, and they'll start to run a fever. Treatment for pneumonia is going to be antibiotics. Urinary retention can also occur after procedure. We're going to see a decreased urinary output, less than 30 mLs an hour. What do we do for these patients? We're going to want to do strict intake and output. We're going to want to see what comes in versus what comes out. We're going to bladder scan them, make sure it's not their bladder that's holding on to fluid. If their bladder scan showing like 600 mLs and the patient's uncomfortable, they're distended, they're unable to pee, we might need to do a straight cath. For surgical sites, we've got evisceration and dehiscence. Essentially, both of these are splitting, but it's kind of the degree of splitting we're concerned about. With evisceration, the patient can split from the surgical site and we will see visible organs. So what do we do as a nurse if this occurs? We're going to want to make sure that we cover the organs with sterile saline and gauze, and we're going to want to page surgery. For dehiscence, again, this is just simply splitting of the surgical site. It's very important that we prevent dehiscence by making sure that the patient is splinting their incision with a pillow and doing coughing and deep breathing, that they're wearing their abdominal binder, they're not engaging in heavy lifting or anything like that. Thrombophlebitis can occur if the patient's not, getting up out of bed. Essentially, you'll see a red, warm, swollen extremity. Treatment, early ambulation is key. If the patient's unable to ambulate post-surgery, unless there's any sort of contraindications, it would be a good time to put some SCDs on them. And then finally, one of the most common one is paralytic ileus. We've got anesthesia. Maybe they had surgery where their abdominal organs were a little bit manipulated, a little bit funky, and can cause some constipation. These patients with the paralytic ileus will have absent bowel sounds. What are we going to do for these patients? We're going to reduce narcotics. We're going to start them on some stool softeners, usually prior to this, like after surgery, daily stool softener, and the metoclopramide Raglan. It's a promotility agent. Alrighty, my dears, and last but not least, we're going to end with end-of-life care. So, common clinical manifestations of a patient at end of life, you'll start to see some mottled skin. Their vital signs will be trending downward. They'll produce some more respiratory secretions and have that Shine-Stokes breathing. A little bit of the death rattle. You'll start to see altered level of consciousness and some disorientation. So end of life care is when patient and family have decided to withhold life-saving treatment and essentially want to focus on a death with dignity, peace, and comfort. This would be in the hospital, they call it CMO, comfort measures only, might be hospice patient, etc. So this is for a patient that's a DNR. We're not providing any life-saving interventions. We're not providing care. Essentially, our focus is going to be on providing them a death with dignity, promoting comfort. The real focus is reducing those respiratory secretions, things like that. So what should we do for end-of-life care? We want to elevate the head of bed, help promote, breathing. We just don't want them to be struggling to breathe, in pain, anxiety, things like that. Morphine and atropine help. Morphine helps with pain, helps relax the patient. Atropine is going to help dry up those oral secretions so they're not having to worry about kind of choking on that. We're going to suction the oral cavity as needed, again, for comfort. We're going to provide supplemental oxygen via a nasal cannula. If the patient was on a ventilator, we're going to remove that. We're going to remove CPAP. We're going to remove BiPAP. Anything that's invasive, uncomfortable, we're going to remove. The nasal cannula will provide them oxygen, but comfortably. We're going to want to do some peri-care on the patient, fully for comfort if needed. Now is not the time. We're going to want to be doing complete bed baths, complete linen changes. It can cause a lot of stress on the patient's body. So if the patient is incontinent, producing a lot of urine, we might just place a Foley in them just for comfort purposes. Consulting a chaplain is always recommended. And as always, the focus is on reducing pain, agitation, and secretions. So what are our don'ts for end-of-life care? We've already talked about we're not going to be doing interventions that cause pain or discomfort. We're going to remove tele. We're not going to be doing blood pressures on them. We are not going to be doing labs, needle sticks on them. We're not going to be doing AccuChecks on them. Anything painful or invasive, we're not going to do. We're not going to provide excessive stimuli. We're not flipping them, changing the bed, anything of this sort, and we're not force feeding the patient. So that is all I have for part 1 of our Medsurg review. If you guys would like a copy of these notes, they are available for purchase on my Etsy shop. The link is going to be in the description, where you will get full PDFs of all of this, plus areas for you guys to fill in your own notes from rationales or whichever notes you might have. We're going to have 2 more reviews for the NCLEX part 2. We're going to be really focusing on body systems such as the respiratory system, cardiac system, neurological system. We're going to do critical care. We're going to do burns, all that super fun stuff. So stay tuned for that. As always, if you need anything at all, please let me know. And thank you so much for sticking with me.